Greetings from Indian Journal of Anaesthesia. I, Dr. Riniki Sharma, will be presenting an article published in the May 2025 issue of the Indian Journal of Anaesthesia. It is titled Ease of Intubation Using Oral Microcuff RAE Ring Adair Elwyn Tube with and without pre-mounted Frova intubating introducer in children undergoing cleft lip and palate surgeries, a randomized controlled study. Airway management in cleft lip and palate surgeries is difficult due to the anatomical distortion. Oral ring Adair Elwyn tubes are preferred for optimal surgical access, but their preformed bend can complicate the tracheal intubation. The Frova intubating introducer improves the intubation ease in both anticipated and unanticipated difficult airways. And it has been recommended by both the Difficult Airway Society guidelines of 2015 and the All India Difficult Airway Association guidelines of 2016 for early use in difficult intubation scenario. So this study aimed to compare the tracheal intubation time between the Frova guided and non-guided oral RAE tube intubation in children undergoing cleft lip surgeries under general anesthesia. So the primary objective was the tracheal intubation time between the two groups. Secondary objectives were the first attempt success rate, need for external laryngeal maneuvers, ease of intubation, and incidence of airway injury. Institutional ethical committee approval was taken and trial was registered in CTRI. It was a randomized controlled trial including participants of ASA group 1 to 2 from 6 months to 4 years undergoing elective cleft lip and palate repair. Exclusion criteria was limited mouth opening, anticipated difficult airway, significant facial asymmetry, restricted neck movement, history of difficult intubation, and recent respiratory tract infection. The randomization was done using a computer-generated random number table, and allocation concealment was by sequentially numbered opaque silk envelope. In the group Frova, the oral microcuff RAE tube was preloaded over a Frova introducer, whereas in group non-Frova, the oral microcuff RAE tube was used alone. All these were done by an operator who has at least 2 years experience in providing anesthesia with cleft lip repair. PAC was done 1 day prior to surgery. In the OT, ASA standard monitors was attached and anesthesia was done with inhalation induction with sevoflurane, after which IV cannula was secured and fentanyl and etracurium was given. In the group Frova, an oral RAE tube was preloaded over a 8 French Frova intubating introducer with its stiffening cannula, and the Frova tube was extended 0.5 to 1 centimeter beyond the RAE tube. Once the RAE tube crossed the vocal cords, the introducer was withdrawn by assistant while the anesthesiologist advanced the tube to its marked depth. In the non-Frova group, the RAE tube was used without a Frova introducer. RAE tube was secured in the center of the chin of all the groups. The correct placement was determined by 3 consecutive square wave capnography and bilateral air entry on chest auscultation. And then the patient was put on the volume control mode of ventilation. The primary outcome was time to intubation, which was introduction of the laryngoscope blade till at least 3 consecutive square wave capnography was obtained. In the secondary outcomes were number of attempts at redirection of tube, hemodynamic response, incidence of failed intubation, ease of intubation, desaturation incidence, and need for external laryngeal maneuvers. A p-value of less than 0.05 was considered statistically significant. So this is the consort diagram where we can see that in the Frova group, 39 were analyzed, and in the non-Frova group, 37 were analyzed. It is seen that there is no statistically significant difference between the baseline characteristics that are similar. In the primary outcome, which was the total intubation time, we can see that it does not differ significantly between the two groups. The first attempt success rate, desaturation, airway injury, requirement of external laryngeal maneuvers, these were all statistically insignificant in both groups, between the two groups. Even the heart rate and the systolic blood pressure between the two groups did not differ significantly. So this study compared intubation time using Frova guided oral RAE tube versus a standard RAE tube in children undergoing cleft lip and palate surgery. Mean intubation times are comparable. The slight delay in the Frova group was likely due to the additional step of introducer removal, consistent with previous findings using introducers. The Frova introducer passed smoothly through the RAE tube without altering its preformed shape, supporting its ease of use in prior reports. The Frova group showed higher first attempt success rate and fewer external laryngeal maneuvers, echoing earlier studies reporting high success with Frova. Although airway trauma occurred in 2 cases due to tip hinging, overall use was safe and avoided repeated laryngoscopy as is seen in previous literature also. The incidence of difficult airway in cleft lip surgeries is found to be around 4.7 to 8.4%, making the early use of introducers like Frova clinically variable. Despite the study's single center design and small sample size, findings suggest that Frova-guided RAE tubes may improve success in pediatric airway management, especially in Cormac-Lahane grade 2 or 3 views. So from this study, the Frova introducer guided intubation with an oral RAE tube did not reduce the intubation time in children undergoing cleft lip and palate surgery, but showed a slightly higher first attempt success rate, suggesting potential clinical benefit. Thank you.